Hi, I'm Shahram Kordasti from King's College London and Hematology Department at Guy's Hospital. Um, and I'm going to explain a bit more about immunotherapy in MDS and the question, is there really a role for immunotherapy in MDS? But before we actually talk about immunotherapy in MDS, what important aspect to a couple of things that we need to have in mind before addressing that question is MDS is not one disease. We know MDS is a very complex and heterogeneous group of diseases, and therefore considering the different aspects from somatic mutation to microenvironment and inflammation, as well as immune response in terms of cellular response, form a very network of immune dysregulation, if you like, that is not a straightforward and is not one type. That's one thing. And second is what we really mean by immunotherapy. When we talk about immunotherapy, immediately we may think about immune checkpoint inhibitors, CAR therapy, which are, of course, immunotherapy. But we should remember, we are not just talking about that. We are also talking about modulating immune response, which I explain a bit more. So from the MDS point of view, MDS, we know far better these days the role of different mutation, how they contribute in disease and disease progression, and how they correlate with the risk of progression. We know very well and with a lot, much more details about the role of inflammation, how inflammation play a crucial role in genomic instability and inflammasome pathway. We know that activation of inflammasome pathway is crucial for creating a inflammatory environment that lead to genomic instability, and at the same time feed a very damaging, if you like, aspect, which is expansion of immunosuppressor cells like MDSCs. So you have in one way an inflammation that creates genomic instability, more mutations, and in the other hand, you're expanding an immunosuppressive environment that prevents any eradication of malignant clone. So that's by itself is a complete network of mutation, genomic instability, and inflammation. If it continues, and of course, even at earliest stage, you will have cell death. This cell death can be, I mean, most of the time, it's immunogenic, and this immunogenic cell death may lead to expansion of T cells, and then T cells recognize the antigen which are spread in the environment, so epitope spreading happen, expansion of T cells, so, and they may contribute to more cell death. So more cell death, more expansion of these T cells, which you can clearly see on some of these patients. So when we talk about immunodysregulation in MDS, we are not talking about one thing, not talking about one mechanism. Is sometimes I call it immunological mess. It's a mixture of myeloid drug inflammation, cellular response, and immunosuppression. And patients may have different presentation based on what aspect of this complex immune response is more dominant. For instance, you see patients with MDS that they have more of a like sweet syndrome MDS, that they have a very predominantly myeloid drug inflammation. And on other hand, you see patients with oligoclonal T cell expansion, which respond very well, for instance, with to immunosuppression with ATG, for instance. So patients are not uniform. Patients have different features, and most of patients, of course, they are sitting between these two spectrum, from a very myeloid type inflammation to the one that may be closer to other bone marrow failures like aplastic anemia. And so we need to have this in mind, that we are not talking about one condition, one mechanism, or one clinical feature. Considering this, it shows how it cannot be that straightforward to decide, okay, we shall give anti-inflammatory drugs to every patient, or give ATG to every patient, or give checkpoint inhibitor. You know, it's cannot be a golden bullet for everyone. No, it doesn't work, and we need to be more specific. In past few years, you know that several clinical trials have been tried to use, for instance, checkpoint inhibitor, with rather disappointing result, although some patients respond, but it's a minority. And the question is now, several other clinical trials are ongoing using different approaches for controlling inflammation. Will any of these be successful? And or we will end up with clinical trials with 10-15% response. I think there is something we need to address, and the issue is, if we rely only on IPSS or IPSSR for stratification of patients to choose these patients for therapy. Of course, IPSSR is an excellent predictor tool, works excellent, very well, but will this IPSSR, which immunological factors have no direct involvement, there is no direct immunological factor in any of the IPSS elements, can be used to decide, for instance, give checkpoint blockade or anti-inflammatory medications to the patient? Most likely not. And we need a better approach. We need to have an approach to stratify patients better, identify those patients that they are dominantly autoimmune type, they have more of the, for instance, T-cell response, therefore they benefit from specific treatments that targeting T-cells, just for argument's sake, ATG, and maybe in those subset that they are hyperplastic MDS. How you define hyperplastic MDS needs more clarification, but that can help. Or the other group that they have more dominant myeloid-derived inflammation, they may need specific therapy. And those patients that they have a very dominant immunosuppressive environment, expansion of Tregs, a combination of checkpoint blockade and treatments that help to awaken the immune system, provide new targets, combining vaccination with checkpoint blockade, combination hypomethylating agent and checkpoint blockade on those particular patients. These approaches, a combinatorial approach, may need for those patients. And some patients with a very complex cytogenetic abnormalities, complex several mutations, may not actually benefit from this type of therapies. And for them, we may need to think for alternative therapies, go directly for bone marrow transplant if possible, if not, to find other alternatives. And the final point I want to mention is some drugs may not consider, if we talk very strictly speaking from immunologist point of view, may not consider immunotherapy like luspatercept or other medication that we use, like lenalidomide, etc. They are not, strictly speaking, from an immunologist point of view, may not consider immunotherapy, but they are they modulate immune response, and they have modulatory effect on the immune system, and they work. And therefore, that is an example that if we choose the patients correctly with right target, they work. And therefore, in the future, we need larger studies with larger cohorts of patients to profile them, identify those patients which are they belong to one of these categories that I've mentioned, and therefore better targeted for therapies, and choose them for right type of therapy. It needs collaboration between centers, need multi-center studies, and hopefully we will have a better picture and better answer in near future.